I have the honor of introducing Dr. Eva Sevick, who is a researcher out of the University of Texas Health Science Center at Houston. And she almost needs no introduction because her research has been both the foundation for and at the forefront of so much of our modern understanding of the lymphatic system. And I just find her scientific curiosity and passion and energy almost as contagious as the new COVID variants. And we are very, very grateful to have her with us here tonight. So with that, I give you Dr. Eva Sevick.
Thank you very much. It's a pleasure to be here, and good evening, everyone, from my home office, and I hope everybody is doing fine. This evening, I'm going to be summarizing a review paper that has come out a couple months ago on the development and treatment of lymphatic dysfunction in cancer patients and survivors. And in the process of this presentation, we're going to be gathering your thoughts on some of the concepts and hypotheses that may come out of this review paper. So I'm really anxious to get your feedback on 3 separate polling questions. Now, before I get started, I have some disclosures to provide. I'm going to be showing you some human imaging studies, and these use an off-label administration of indocyanine green. And this is conducted under IRB and FDA clearance. Now, the studies that I'll be presenting, I'm going to present a number of these studies that review a certain concept, and they're funded by Tactile Medical, the Cancer Prevention and Research Institute of Texas, Kimberly-Clark Corporation, and the National Institutes of Health. Now, I'm a paid speaker for Tactile Medical, and I have equity interests in a startup company called Lymphatic Science, which is producing investigational devices that were imaging the lymphatics, and we're commercializing the technology for clinical applications of lymphatic diagnostics, including the early diagnosis of cancer-acquired lymphedema. Now, my hope today is to impress upon you the impact of cancer progression and cancer treatment upon the lymphatics. You know, we usually, when we talk about cancer-acquired lymphedema, it's after the fact. But I think it's important to understand what's happening to the lymphatics during cancer progression and during cancer treatment. And I hope to convince you that there's abnormal lymphatic pumping, which is a natural phenomenon, but that when it's chronically occurring, this causes dermal backflow. And you know, there's some studies we may need to think about dermal backflow rather than edema being the earliest indicator of lymphatic dysfunction. And at the end, I'm hoping to convince you that physiotherapies, pneumatic compression, and manual lymphatic drainage, which is you're seeing in this video here of the lymphatics in the arm. These are the cubital orbital lymph nodes. That this pneumatic compression may play a role in not only treating lymphedema, but actually perhaps preventing it, and providing a cure if we treat early. But before I go into this, I need to give a really brief, very short introduction into the lymphatics so that we're all on the same page. And my discussion is really going to be focused on the lymphatic capillaries, or the initial lymphatics, and the lymphangions. So, you know, Stanley Roxon says the lymphatics are the forgotten vasculature. It's a unidirectional one-way system that starts at the lymphatic capillaries, or the initial lymphatics. And that's where metabolic waste products, fluid, immune cells actually enter into the lymphatic system. They enter and they are collected and conducted, oftentimes against gravity, and return to the blood circulation up in the neck. And through that process, this lymph actually travels through lymph nodes, which is where our immune responses are mounted. Now, the lymphatic capillaries are really unique because they're the unique structure of the vasculature that allows entry into the lymphatic vasculature. So the initial lymphatics the capillaries consist of lymph endothelial cells that have no basement membrane and open and close, and they allow, you know, waste debris, cell debris, immune cells, dendritic cells that actually carry antigens to lymph nodes for mounting immune responses, or carry vaccines to lymph nodes for mounting immune response. Once in that, those lymphatic capillaries, lymph then is pumped through these lymphangions. I call them lymph hearts. They're basically segments of these of the lymphatic vessels that are bounded by bicuspid valves and smooth muscle cells. These smooth muscles contract to propel lymph, oftentimes against gravity. We really don't know what controls this action. We believe it's driven by the autonomic nervous system because there's innervation, but there's also some other components we'll talk about, one of them as it relates to inflammation that may occur with cancer treatment. The lymphatics are part of the cardiovascular system. When you see a picture of arteries and veins, you really should also see the lymphatics, because the microvascular unit, which is responsible for delivering oxygen and nutrients to the interstitium, it wouldn't work unless there was this lymphatic component to pick up that filtrate, to keep up homeostasis and equilibrium. It turns out that in 1898, the Starling's law said that, all this fluid, this capillary filtrate that carries the nutrients to the interstitium was returned to the venous end. But we know there's a glycocalyx that acts as a semi-permeable membrane, and that there's very little fluid that normally is reabsorbed into the venous end of the microcirculation. Predominantly, all that filtrate is returned to the blood vasculature through the lymphatics. So that theory is really relatively recent, since 2010. And under normal conditions, anywhere between 8 and 12 liters of lymph or capillary filtrate is returned to the blood vasculature. So you really can't talk about cardiovascular health unless you're really including the lymphatics. Really important these days, and I think we're going to get an awful lot more attention on this, is that the lymphatics are really part of the immune system. You really can't talk about immunity unless you're talking about the lymphatics. I told you that lymph drains through these lymph nodes. These lymph nodes are where naive T and B cells all reside in the body, just waiting to be educated upon what antigen to attack. And these antigens or foreign proteins or particles are picked up by dendritic cells that enter into these initial lymphatics that are right underneath the epidermis. And these dendritic cells actually mature as they move through the lymphatic capillaries or the conducting vessels. And when they enter into the afferent vessels of these lymph nodes, they migrate to where the T cells and B cells are located. These antigen presenting cells then basically reach out. They present to the naive T cell the antigen to educate the T cell, like, go ahead and attack this antigen. And if that T cell is successfully activated, then what will happen, there'll be a proliferation of T cells that are activated against that antigen. Those T cells will then leave the lymph node through the efferent lymphatic vessel and get into the bloodstream, so that we have systemic T cell, activated T cells that are circulating through our blood vasculature to seek out and destroy on the basis of the recognition of that antigen. In addition, those activated T cells can actually migrate to the germinal centers where the B cells are located, and basically educate the B cells so they produce antibodies against that antigen. And then those antibodies will then leave the efferent vessel and get into the bloodstream. And again, we have systemic immunity. So what's really interesting, and hasn't gotten a lot of press really thinking about it, is that we set up systemic immunity within regional lymphatic watersheds. That allows us to get a bug bite or a mosquito bite on the foot as well as a bacterial infection in the hand, and be able to fight both of those, set up immunity to both of those without overwhelming the immune system. So that's kind of interesting that our immune system works on a lymphatic watershed basis, not systemically. And that's going to come up a little bit later on. Now, we haven't had a lot of ways to actually look at the lymphatics routinely. You know, lymph is colorless. You know, you don't see it. You don't see, you know, lymph vessels when you do surgery. So we've been developing this near-infrared fluorescence technique for quite some time. It depends upon injecting a, 100 microliters or a tenth of a cc of a diluted indocyanine green. We only inject about 25 micrograms of indocyanine green right underneath the epidermis where those lymphatic capillaries are located. Once we do that, the dye goes immediately into the lymphatic collecting and conducting vessels. We illuminate the tissues with near-infrared light. Light penetrates through several centimeters of tissue. And then what we do is we use a camera system to look at the fluorescence. And this is the kind of image that you get. This is an injection in the foot of a person with lymphedema. I know that because the dye is draining to the bottom of the foot. Everything always goes distal to proximal. The camera is so sensitive, will oversaturate the camera. So we usually put a Band-Aid over the injection site, and you'll see a little bit later on, we put black opaque tape so that the light doesn't shine through the tape and oversaturate the camera. So the device is based upon military technology, night vision technology. And we started this after the first Gulf War. And we've now adapted it into devices that we're in the process of commercializing. The technology is so sensitive, we can look at like 3 to 4 centimeters deep. We can see the lymph nodes in the body. We can see the axillary lymph nodes, the lymph nodes in the elbow, the groin, underneath in the knee. And we can do this actually with a trace amount of agent. What's really kind of interesting, and this is the only engineering slide that I'll put up. I like this slide. So it's interesting that the technology provides us a very high signal with small noise. That means that we have an exquisitely high signal to noise ratio. So we're way up here, and yet we have a very high contrast. So you want high signal to noise and high contrast so you can see it really easily. And using these standards that have been developed with NIST and a talented person in my lab, his name is Bangui Zhu, basically we've shown that our devices operate in this range. So they're incredibly sensitive. If we compare them to the Hamamatsu PDE Neo 2, they're down here. So you can see an awful lot more with this technology. What's really kind of interesting is we can take images as fast as 50 to 200 milliseconds so we can stitch them together, and we can get movies so that we can see lymph pumping like this in the arm. Usually we make injections at the top of the hand, and here you see we have a couple of injections right before the elbow. And you see this video is sped up about 3 times, and you see this movement of lymph. It's not related to motion. These are people that are standing, that are lying still or standing still. And it's not related to respiration or heartbeat. What's happening with this lymph, one aspect of lymph pumping arises due to nitric oxide, cyclic nitric oxide production within the lymphatic endothelium. Consider this as a lymphatic vessel with smooth muscle cells and the lymph endothelial cells. This is in a conducting vessel, so it's a mature vessel. And it turns out whenever there's flow from your fluid dynamics, you'll have a high shear stress at the endothelial side. And it turns out that that shear stress causes the cells to produce endothelial nitric oxide synthase. Okay, so whenever there's high shear, we have eNOS produced, which results in nitric oxide, which is a potent vasodilator. So what happens is when there's shear, we have NO produced and the vessels dilate in that section. So as the vessels dilate, the flow decreases, the shear at the wall gets smaller. And so that shear-induced eNOS NO production reduces as well. So you get this cyclic contraction, relaxation, contraction that goes on. And each person has a different rate of this pumping that occurs. It occurs at different rates depending upon the lymphatic load. And it also changes with inflammation. So whenever one has inflammation, one typically has a number of pro-inflammatory cytokines, with the key players interferon gamma, TNF alpha, or IL-1 beta. And these cytokines are pretty potent. And in fact, in the endothelial cells, the lymph endothelial cells, through the NF-kappa B pathway, they actually produce inducible nitric oxide synthase. So it produces NO not based upon any shear induced mechanotransduction. It just produces NO because there's all these pro-inflammatory cytokines. So what happens is in the presence of these cytokines, there's so much NO, it swamps out the enos, and you just have so much NO that these lymphatic vessels dilate. We can't necessarily test this in humans, but we can do this in rodents. Rodents don't have a lot of lymphatics. And what I'm going to show you is lymphatic imaging from an injection in the foot and the hind paw. It goes to the popliteal, the inguinal node, and then the single conducting vessel that goes to the axillary lymph nodes. So normally in animals, this is without any sort of pro-inflammatory condition. Let's see if that works. What you see is this lymph nodes filling and you see this pumping that's going on. Now, if we take a lipopolysaccharide that comes from a gram B negative bacteria, what will happen is we inject that and we see that the lymphatic vessels are actually dilated. So dilated, the bicuspid valves don't attach, and we don't have this efficient pumping. In fact, you'll see that the lymph node is actually kind of smaller compared to the animal that was not under this insult. Now, eventually, this condition alleviates after 4 hours, but nonetheless, this acute inflammation causes these lymphatic vessels to dilate. And so lymphatic transport is somewhat impaired. Now, one pro-inflammatory cytokine you might hear about a lot at night with the commercials for Humira or Enbrel is the TNF alpha, which occurs with a lot of autoimmune diseases, including rheumatoid arthritis. And we thought that, well, if these cytokines are really involved in lymphatic dysfunction in autoimmune disorders, we should be able to test it and image it in animals. So we induced an RA-like condition in an animal in the hind limbs of a rat. It's a collagen-induced arthritis model. And what happens in these animals, we have all this TNF alpha throughout the animal. And what happens is that the animal's hind paws get inflamed, swollen, and it turns out that their lymphatic function deteriorates. So we hypothesized that if we put this antibody against TNF alpha, that we neutralized it and stopped this iNOS induction, we may have a quicker recovery. We ended up using a lymphatic delivery device that was developed by Kimberly-Clark. There's a number of these devices under development at this point in time. And it turned out when we delivered TNF alpha to the draining lymph nodes of the hind paw, we found incredible effects. This is the picture of the lymphatic imaging of the hind leg of a rat that was untreated. We also had the same behavior whenever we gave the etanercept or the anti-TNF alpha subcutaneously. The lymph flow is supposed to go from the paw to the popliteal node. And this is what you see. Actually, you see it going backwards. So clearly the pressure gradients aren't set up so well. The popliteal lymph node isn't very bright. But when we delivered the biologic to the lymphatics via this lymphatic delivery device, what we saw forward lymphatic drainage, and that popliteal lit up. So I hope to convince you that the lymphatic function is mediated by the inflammatory conditions. And many of these autoimmune disorders that are occurring as we age may be caused by lymphatic insufficiency. But let me move a little bit further on this. And these autoimmune diseases are not usually acute; they're usually chronic. And so, under chronic conditions, we might expect to see more deterioration of the lymphatics. Let me explain. So these initial lymphatics drain into these conducting vessels. And whenever we have this lymphangion that's pumping, we're creating somewhat like of a suction. And so we get material moving in these initial lymphatics through the collecting and into the conducting vessels. However, when we have a cytokine storm that's in these lymphatics, the vessels are dilated, the valves are not working very well. These lymphangion segments fill up with fluid, pressure increases, and basically we hypothesize what you get is you get lymph flowing backwards. We call that dermal backflow. And so we've seen this phenomena of dermal backflow, and we've actually also seen this in autoimmune conditions. This is a study subject that came in his left wrist. He had pain, arthritic pain, swollen joints, little bit of swollen wrist. And when we did the injection of his normal arm, you see the nice, beautiful lymphatics, but his affected arm, he has dermal backflow. So this inflammatory situation may be interrupting the pressure gradients that are associated with an otherwise functioning lymphatic vasculature. So I have a poll question for you. This is the first poll question. And here it is. When there is inducible nitric oxide that is produced by immune cells or cytokines, and these cytokines, after all, these lymphatics are supposed to pick up, the metabolic products, and those are the cytokines from the interstitial space. The recovery of lymph can most logically be performed with A, surgery, B, physiotherapy, or C, approved lymphatic delivery of neutralizing antibodies. Let's see what we've got. And while you're watching, let me see if you can see this. This is the picture of the lymphatics in an arm of a breast cancer patient. 2 injections in the wrist, 1 injection here. These are the most, I'll show you a little bit later on, these are the most important injections on the wrist and the dorsal aspect of the hand, as well as the feet. They're great places where to get into the lymphatics. Let's see, where are we now? Are we almost ready? Oh, okay, this is an unusual. We had 0% surgery, physiotherapy 53%, approved lymphatic delivery of neutralizing antibodies. Well, number one, no antibodies are approved for lymphatic delivery because the FDA doesn't really understand how you do pharmacokinetics in the lymphatics. So I think right now there's no approved lymphatic delivery, although it would be kind of interesting. But, maybe it is that physiotherapy is really the way to go. You can basically just push all those cytokines out of the lymphatics. And this is in the normal arm that I showed earlier. And this is actually in the patient. This is Carolyn Fife had presented this some years ago. This is in a patient with lymphedema, lower extremity lymphedema. And when MLD was started on the toes, you started to see the lymphatic pumping. And up above, we see that there's a dermal backflow. And the idea that we do MLD to stimulate lymphatic pumping, and that stimulation may be just moving, getting all that fluid, pushing all that toxic metabolic waste and cytokines out of the lymphatic compartments into the bloodstream for processing. So let's see. So what we need to talk about now is how does this all relate to cancer progression and treatment in the lymphatics? And as a segue, I put this image in. This is an image of a gentleman some years ago who came in. He had carpal tunnel syndrome surgery. And he ended up with some edema in the back of his arm. And what's really interesting here is you see this bundle, this main lymphatic bundle feeding to the axilla. And what he had these new lymphatic vessels formed through the process of lymphangiogenesis. I know that because it's basically tortuous lymphatic vessels. So the body tends to grow new lymphatics to actually move fluid away and bring it into the proper lymphatic watershed. Tumors are kind of similar to that in that when tumors grow, we know that they grow their own blood supply. That allows the nutrients, the oxygen to come in. But those new blood vessels are pretty leaky. They're grown real quickly. So these neovasculatures are highly permeable. There's a lot of capillary filtrate. And it turns out that most tumors do grow their own lymphatic supply. And that lymphatic supply is connected to a tumor draining lymph node. So I've already talked about these lymph nodes as the site where immunity, local immunity is established and the adaptive immune system starts. And so the question can arise is if these lymph nodes are such inhospitable environments for foreign substances and a tumor is a mutated cancer cell, why are these lymph nodes the site, usually the first site of metastasis? And it turns out that they're also the first site where cancer hijacking of the immune system actually occurs. It turns out that cancer, these neoantigens, these mutated proteins that come from these cancer cells are picked up by dendritic cells. They migrate to this tumor draining lymph node, and they're there to educate the T cells. And you would think that if we have a really robust immune system, that when that antigen presenting cell basically presents the cancer neoantigen to the T cell would say, oh, okay, I should go out and attack this. But the problem is that neoantigen from the cancer looks an awful lot like self. And the immune system's smart. And it says, wait, before I'm taught to attack this cancer antigen, I'm going to stop. I'm going to put the brakes on. And so there's something called co-inhibitory signaling that actually occurs that stops the activation of the T cells and the proliferation of these educated T cells. And in that process, in that lymph node, the tumor cells now become immune privileged. So the lymphatics are really important in terms of allowing cancer progression, because that's where tolerance of cancer is actually maybe established. So therefore, the lymphatics is really a primary site, primary route of dissemination of many cancers. So cancer cells migrate to the lymph node, and then from the lymph node, they go to the bloodstream, and then they're everywhere, right? It's distant metastasis. So our cancer treatments are to remove the primary tumor if possible, and oftentimes remove the draining lymph nodes because we're removing the route of dissemination. And then we follow afterwards with radiation, just some of the treatment aspects. But what does radiation do to the lymphatics? Well, it's interesting. The radiation actually causes cell death. And when we have cell death, we have these innate immune responses that are immediate immune responses. They're caused by all this material that's produced by these necrotic cells, these dying cells. So these dying cells produce something called DAMPs, or danger associated molecular patterns. And these stimulate the local immune cells. And they rev up, the neoantigen presentation to these dendritic cells. So basically what happens after radiation, what we can expect is that, there's a lot of neoantigens, the immune system is all revved up. And so there's effective education of these T cells that now at this point, there's no co-inhibition or less co-inhibition. And now we get this proliferation of immune cells and antibodies that, if that lymph node is still there, could cause systemic immunity. Problem is that oftentimes we remove these lymph nodes before we do the radiation. So this radiation causes this innate immune response with these cytokines all over the place, and the lymphatics are impaired to clear that out. And so that may set up for this chronic inflammation that may be perhaps the root cause for cancer-acquired lymphedema. To show this, I had this wonderful, very talented faculty in my laboratory. His name is Sungkook Kwon. He did this experiment. It's really beautiful. He took an animal, very, very careful, and he removed the popliteal lymph node, and he took some of the fat pad associated with it just to mimic the surgery. After he removed the lymph node, he let the animal recover for 40 days and dosed the animal with radiation. He did a control, 20, 40 gray, and even did a fractionated dose, kind of mimicking what is done in cancer treatment. So pre-surgery, when you inject in the animal, the hind limb, you basically get to the popliteal lymph node, and you see these beautiful lymphatic vessels. After surgery, now the popliteal is removed, so now you get the drainage to the inguinal lymph node. But the lymphatic vessels are all pretty much intact. But when you give the radiation, this is what happens. I hope you can see this. In surgery, you get a little bit of lymphatic remodeling, but 25 weeks after, you still have wonderful lymphatics. If surgery, 40 days, and then give a single dose of 20 gray radiation, you see at week 2, you get some dermal backflow. We get, ICG moving backwards. And it recovers somewhat so that at week 25, we're looking a little bit better. When we give 40 gray, what happens is we get dermal backflow that seems to be persistent. Now, what's kind of interesting is like at week 4, we get fibrosis. We don't get swelling, we get fibrosis. And that kind of mimics what we see in head and neck cancer patients, and we'll talk about that a little bit later on. But it's the fibrosis that we see. And in breast cancer patients, we see fibrosis later in cancer acquired lymphedema. What's really kind of interesting is that these lymphatic vessels, these are some micrographs of the lymphatic area, cross-sectional area. We find that as we give more radiation, the lymphatic cross-sectional area, the diameter of the vessels gets bigger. The number of vessels don't get bigger, but the diameter does. And because the diameter is bigger, the bicuspid valves don't match the contraction, the motion of those lymphatic vessels actually decrease one day after therapy with both 20 and 40 gray. They begin to recover at 20 gray at 1 week. And at 25 weeks, the animal with 40 gray, the contraction frequency is significantly less. And again, there's dermal backflow. Now, what's interesting is that if we look at fractionated radiation, we give 20 gray in a single dose, but we've decided that it's better for people to get fractionated radiation rather than a single dose. And it turns out that the animals that were given fractionated radiation actually have worse conditions 4 weeks after radiation. We haven't ran the study out far enough to see if that effect holds, but it points out that when we were figuring out how to give radiation to cancer patients, we weren't thinking about the lymphatics. And we took out the lymph node that is really associated. We impaired the lymphatics with lymph node dissection that is probably responsible for helping to clear all those inflammatory cytokines from the site of radiation. So here's the second poll question. Physiotherapy during or immediately after cancer therapy, and you should select all that apply, can promote cancer metastasis. can promote anti-tumor immunity, okay, which would be kind of the opposite, and could prevent cancer-acquired lymphedema, or would have no effect whatsoever. Let's see what you guys all have. Obviously, this requires a clinical study, but it's a good hypothesis. It's the idea of thinking about what's the cause. We may be able to do the clinical study with a hypothesis that's based upon some rationale. Let's see where we are. Okay, we're done. I like the results. Could prevent cancer-acquired lymphedema. I kind of think so. If we can make this acute inflammation, you know, we can resolve it by moving lymph out, you know, of the area, then we may be able to prevent cancer-acquired lymphedema. We could promote anti-tumor immunity. I think we could. It's a long clinical study. Could promote cancer metastasis. You know, some of you have said, yeah, you can, you know, some people have said that, you can't do the manual lymphatic drainage until after the cancer is definitely gone. You know, if the cancer is definitely gone, if it's still there, you know, it might help in terms of establishing anti-immunity if it gets to the lymph nodes, if you can establish anti-tumor immunity. So obviously, there's no right or wrong question. We need clinical trials to actually address these. Let's see, our next aspect is I'm going to talk to you about abnormal lymphatic pumping and dermal backflow as the earliest indicator of dysfunction. So, you know, when should you treat? Okay, you know, it's possible that this dermal backflow is natural and it does resolve, but you know, when really should you be treating for cancer-acquired lymphedema? Right now, we treat whenever there's a 5 or 10% increase in swelling. This is an early breast cancer acquired lymphedema subject. She's symptomatic, she has an increase, but you see this dermal backflow. These are some of the images are really beautiful. They're very lacy. And so you'll do an injection and the vessels go deep, and then the ICG comes up to the surface. And the surface is so bright it oversaturates the camera, so we don't really see this, the deeper vessels, unless we cover this so that we can actually get the dynamic range of the camera. But this is the dermal backflow that we often see in early stages. We don't see this in late stages, but in early stages. I'm going to talk to you about head and neck cancer, because head and neck cancer, you don't really have a good edema, measure of edema. And when we talk about head and neck cancer, we usually talk about the external lymphatics, and we can image, because we're doing a trace dose. So you don't see the indocyanine green. We're not giving anybody a tattoo when we do this. So we can do the injections right on the face and you won't see any marks. So we'll give injections before and after the ear and one in the submandibular area. And basically you'll see this lymphatic drainage, and we call this the external lymphatics. We also do an injection in the back of the throat with a spinal needle. And this is done by Ron Carney, who is just an incredible head and neck surgeon who has worked with us on this, and he's helped develop this technology, this technique. What he does is he puts it near the tonsils in the back of the throat, and that's a lymphoid organ or tissue. And what happens is that drains all the way to the chain of lymph nodes right beside the jugular vein. That's kind of deep, but these are the lymph nodes that they remove in lymph node dissection. And here you see them. Interestingly enough, in these cancer patients that we were imaging, we didn't see drainage to those lymph nodes. It's kind of interesting, suggesting that they were somewhat immunosuppressed. And there was not that immune response that may have been occurring. But let's talk about what happens to these patients after, they're diagnosed. Here's pre-lymph node dissection. 7 weeks after lymph node dissection, there's no dermal backflow. You'll see a little bit, it's hard to see here, but there's some lymph nodes there. But 21 weeks after radiation, you see this profound dermal backflow. And once this dermal backflow appears, it persists. It doesn't go away. They don't always have swelling or what we can measure as swelling, but they do have onset of fibrosis, and they have mobility problems. Is this cancer-acquired lymphedema in head and neck? And you have to wonder that. And should we be treating these patients as soon as we see this dermal backflow? I hope I've convinced you that dermal backflow is not normal. We do not see it in normal subjects. And we've done about 600 infants and children and adults, and we've never seen dermal backflow in healthy individuals. This is some recent data that comes out of MD Anderson and Melissa Aldrich, who's a faculty member in my team. And she was basically taking advanced breast cancer patients, and she was imaging them at diagnosis, after axillary lymph node dissection, and as a function of time after radiation treatment. And what you see is that after lymph node dissection, she sees some dermal backflow. 6 months post radiation therapy, more dermal backflow. 12 months, she's even got more dermal backflow. This is the view, the medial arm holding the arm over the head, and you see this incredible dermal backflow that's appearing. Interesting, when she did the relative volume change, when we first see the dermal backflow, we don't see swelling. In fact, the contralateral arm is larger than the arm that should be affected. And we didn't see that increase in arm volume until a year later. And so the question that comes is, if we treated this breast cancer survivor when we first saw dermal backflow, could we have prevented this? And is edema really the right measure, or is it too late to basically do treatment? I should also say this dermal backflow isn't always due to the mechanisms of impaired pumping due to radiation treatment. This is a dermal backflow in a patient. This was before treatment, and this was an IBC patient. Most of the IBC patients, we have cancer metastasis through the lymphatics. And you get to see the orange, the peel appearance of the skin. And this actually also occurs with, it's also indicated by the dermal backflow measurement. So dermal backflow can also be indicative of metastasis through, or blockage through the lymphatics. So what I want to talk to you next is what's the evidence for the mechanisms of action of successful treatments to prevent lymphedema, treat. And I'd like to think about preventing, because maybe if we start to think earlier in the course of the condition, we may be able to reverse the outcomes, the eventual outcomes. I'd just like to point out that, you know, the hands and the feet are great places to see if something's wrong. And oftentimes, I guess the therapist would know that, you know, oftentimes you'll see changes in the hands before you see changes in the arm. This is a gentleman who had breast cancer surgery, comes in, he had no volume change, contralateral volume change. He says, I feel a little bit heaviness right here. And lo and behold, there he had dermal backflow. This is a lady who was very advanced cancer-acquired breast cancer lymphedema, and an injection at the top of her dorsal aspect of her head, and the ICG goes to her fingers. And when she turned her palm over, there was the ICG leaking out. She thought it was sweat. It was actually lymph. So these are very advanced stages. We want to prevent that from happening. And so the question is, and this goes back to the prior polling question, is, you know, should we really be giving treatment physiotherapy in some cases during radiation, or maybe even immediately after? We can promote anti-tumor immunity because we get those dying cells that carry the neoantigen to the lymph node, so we can promote systemic immunity. And we can also, like, remove those pro-inflammatory cytokines from the lymphatic space and basically mitigate this inducible nitric oxide synthase and basically restore enos activity so that we have natural contraction. This is a study, I love this study and I want to do more of it. And maybe, actually I want to get the imaging out so that you can do more of it. But this is a patient that was 4 weeks, no lymph node dissection here, but 4 weeks post radiation treatment. And you can see, you might think that he's got some swelling. Of course, we haven't seen the pictures beforehand, but we did the injections, ICG injections, around the ear and on the chin. And this is nasty, nasty dermal backflow. It's going the opposite direction. It's going up. He's sitting up and it's going this way. And you can see a little bit of his lymph node here. Well, what we did is we gave, Tactiles funded this study. And we treated, he comes in and we basically do the imaging. We put them in the tactile garment, do a 30-minute section, and then image again without doing any more injections. And then we send the study subject home for 2 weeks saying, do this daily. Because we know that it's not a single section that cures us. It's longitudinal. You got to be consistent with it. And so this gentleman comes in 2 weeks later, and we thought we mixed up the patients because we've never had this happen. Once we have dermal backflow, we always have dermal backflow. And this gentleman, there's the injections, and you don't see really beautiful lymphatics, but look, there's no dermal backflow. And look at that lymph node. That lymph node is blazing green. It's fluorescent. So there's drainage to that lymph node where, 2 weeks before there was not. So the question is this is one case. Would this help in breast cancer? Would this help in other cancers? And would this resolve on its own? And these are questions that we don't quite know. So here's a poll question, another poll question. The impairment of lymphatic function after cancer treatment, number one, is probably an acute immune response of the lymphatics to successful cancer treatment, okay? Is probably necessary for anti-tumor immunity, should be treated immediately upon detection and before onset of swelling with physiotherapy or surgery, maybe not surgery, who knows, could be predictive of cancer-acquired lymphedema and treatment if persistent, or definitely inconsequential to survivorship or quality of life. See what you guys think about that. Remember, all these lymphatic changes, they're occurring because the innate immune system, there's this raging cytokine that's spilling into the lymphatics. Remember, the lymphatics are supposed to pick them up. And so let's see what we've got here. Is probably an acute immune response to lymphatics to successful treatment. I can agree with that. Yep. Is probably necessary for anti-tumor immunity. I don't think that's the case, because if the drainage from the tumor or from the watershed is going back to the skin, there's not much immunity there. It's got to go into the lymph node to do that. So I'm not so certain that's a good answer. But I agree, it should be treated immediately upon detection and before onset of swelling. A clinical trial is needed and could be predictive of cancer-acquired lymphedema. Could be. A clinical trial is needed. And I'm so happy that everybody says it's inconsequential, because that's not, this behavior, this dermal backflow is definitely not normal. So in summary, tonight, I hope I've given you an insight that we maybe need to look earlier. And by the time the swelling occurs, it may be too much. Chronic conditions of autoimmune disease, for example, RA that I showed you. Oh, and by the way, RA is a comorbidity of cancer-acquired lymphedema, especially in breast cancer patients. Each of these RA and cancer-acquired lymphedema involve lymphatic dysfunction early in the etiology. This seems to be apparent. Lymphatic dysfunction may be caused by inflammation and iNOS-mediated disruption of the lymphatic pump. Makes sense. Whether disruption is accurate or chronic may determine whether there is progressive lymphedema. So if you see that dermal backflow and it persists, that's when you're going to get edema and or fibrosis. And maybe you want to prevent that from becoming persistent. And so you want to keep it from becoming chronic. And my last 2 points are we need an awful lot of clinical trials to determine whether dermal backflow or persistent dermal backflow is an accurate predictor of cancer-acquired lymphedema. Think the savings that we would have and the quality of life of our cancer survivors if we could basically prevent lymphedema or the debilitating effects of having the immune system disrupted the way it is. Because not only is it lymphedema, but we basically are impairing the immune system. So by giving these cancer patients their immune system back, i.e. their lymphatics back, we're going to improve the quality of life for them. Thank you so very much for your time. And it's been a year since I've done a webinar or even a lecture. And so I appreciate the opportunity to talk to you today and share some of our insights. Thank you very much.
Well, thank you so much, Dr. Sevick. We are going to move into the Q&A portion of this evening's webinar. We already have some questions in the Q&A, but just as a reminder, please go ahead and ask any questions that you have through the Q&A icon rather than the chat. It just helps us to make sure we get to your questions. I'm going to take the first one because it's the only one I'm qualified to answer. And the question is, how do I share this recorded presentation with a physician? Attendees of this webinar will be getting a follow-up email with a link to the file that's been uploaded, and you can forward that on to share this presentation to those who weren't able to attend this evening. So with that, we'll move on to the questions for Dr. Sevick. So let's start with one question that came in early in the presentation, and I think there's an autocorrect in there. She asked, is there anyone studying the use of and I think she meant to say TNF alpha to treat lymphedema? Yes.
Yeah, I believe there has been, but let me, and I don't think that's been successful or useful. And I have to go back and look at it, but let's just think about this. TNF alpha is usually given sub-Q, right? So you miss the lymphatic vasculature, right? And if you have, even if you had lymphatic vasculature around, it's not moving, right? So even if you did deliver indocyanine, or not indocyanine, but even if you did deliver an anti-TNF to the lymphatics, it's just sitting there. You're going to have physiotherapy, aren't you? I really think that drugs may not be the end all in this, in getting the lymphatics to move again. I think physiotherapies are really what we need, because after all, if this contraction all depends upon shear, that's fluid flow, maybe the best way to basically get fluid flow and this shear going is basically empty the lumen of the vessels with physiotherapy and then reestablish that shear so we can get that pumping going again. So I'm less enthusiastic about the drug because, number one, they're not delivering it lymphatically, they're delivering it systemically. And TNF alpha itself is an immunosuppressant, right? So you have to worry about TB, you have to worry about other infections. So, there's always a sequela of effects that you have to consider. So I remember somewhere reading about the TNF alpha in cancer-acquired lymphedema. I don't think it was successful. I wouldn't expect it to be successful. I hope I answered your question.
The next question we have, I'm actually going to sort of group two together. One asker asks, how does your imaging different from lymphoscintigraphy? And I'll kind of pair that with a second question, just asking is there a clinically, how can you clinically detect dermal backflow post-cancer surgery or radiation?
Okay, so lymphoscintigraphy is a radiocolloid. It's acid. It's basically a radioactive material, and you have to put it in the webs of the finger. It's actually kind of painful to do. It's not a procedure that you can do in the office suite. You have to inject it, wait for a couple hours, and then sit under a gamma camera, and you get a static image. In the United States, we don't do very many of them because they really don't tell you very much. By the time you get an abnormal lymphoscintigraphy, you already had swelling and you can see it. So, that's a procedure. There are other technologies using gadolinium and iodinated contrast agents. They're viscous agents. They don't go into lymphatics. In fact, in children with vascular leaks, sometimes they plug up the leaks. So I don't think you want to use them for diagnosing early stage cancer-acquired lymphedema. The technique that we use is like, it takes a couple, I could have done about 5 or 6, not I, but my team could have done about 5 or 6 people in the amount of time that we spoke. So it's no more than putting an intradermal injection like a TB test and then shining the light on, and you would see the imaging right away. I would think you could do it in about 10 minutes. So, I always think about, we do these tattoos and you have to have tattoo parlors. I think it would be we're putting a lot less material in, and it's much faster, I think, to actually look at your lymphatics than even doing the tattoo. So we're just putting a little bit of material right underneath the tissue. I hope I've answered your question.
Yeah, and the second part, is there any way that you can clinically identify patients who have dermal backflow without using ICG?
No.
Yeah. I want to be respectful of time just in notifying attendees that we are at the hour. Dr. Sevick has graciously agreed to continue answering Q&A, and so we will continue to chat and record this, but just wanted to mention the time in case anybody had a hard stop. The next question that we have is, do lymphatic capillaries exist only in the superficial dermis? What about other organs than the skin?
Yeah, so it's around the brain. They're around the brain. They're around the eye. They're around every organ. Okay, and the skin is an organ, and it makes an awful lot of sense that there's initial lymphatics, because if you break the skin, that's to keep antigens out. There's a lot of lymphatics, mucosal lymphatics in the oral cavity. So the lymphatics they line every organ, and they basically protect that organ, and they line every tumor, right? They protect that tissue, and by removing the metabolic waste, metabolic products from that tissue.
Thank you. This next question asks, do you think it would be appropriate to supply patients in lymphedema prevention programs with a compression pump to use throughout radiation as a preventative measure?
I've been reading that in the Norwegian countries, and Scandinavian countries, that they are doing that. The issue is that whenever these patients have radiation treatment, often they're kind of sore, and if they can tolerate it, in some places they are doing that.
Thank you.
It's investigational. It's an investigational.
Yeah. This person asks, do you have a video of a distal area of flow during proximal MLD of lymphedema in a limb? Is that something you've seen on imaging?
Sure. So, my goal is I could provide all these. We have too many images to present. It's overwhelming. my goal is to provide the images to you guys so you guys can look at it. The question is, so you're looking at the hand, maybe, and you're doing massage in the axilla, for example. So it's really interesting is that when you do massage anywhere, you'll start to see pumping. And actually you'll see it in the contralateral arm as well. So, so that's why it's odd. We think there's some innervation associated with this. So, so yeah, when you empty the draining lymph basin, you'll increase your lymphatic pumping rates. I don't have studies of that, quantitative studies, but we've observed that.
Yeah. This person asks, I have several patients with fibromyalgia who report feeling, quote, so much better, unquote, after MLD and compression. Could it be that CDT is reducing an inflammatory response that is resulting in decreased fibromyalgia pain?
Yeah, isn't that so? That's a really good question. You know, yeah. I mean, you know, what's causing the pain, basically because they have inflammation in the nerves, right? And so basically what you're doing is you're removing all those cytokines that are around. You're encouraging the immune cells to not attack self. I think that would be that's a good idea. Yeah.
This attendee asks, for metastatic breast cancer undergoing palliative treatment with stable disease, do you think MLD is beneficial?
I'm sorry, can you say that one more time? I apologize.
No problem. They ask, for metastatic breast cancer undergoing palliative treatment with stable disease, do you think manual lymphatic drainage or physiotherapy would be beneficial?
I think if they feel better, yes. Why not?
Perfect. This next question asks, do you see ICG to be used for or like as a companion with MLD treatment? And do you think it'll be used as standard of treatment going forward?
You know, the therapists are really responsible for this program because they were the one that said, oh, we got to do this. And the therapists are really the ones that have used the technology to actually say where we have the dermal backflow. And you know, I for one find it very difficult to figure out how to direct your treatment when you don't see what you're treating. So yeah, I think it would be a good thing, at least in training. It would be really a good thing to do. But to direct therapy, we've had a number of compassionate use cases. We've had one head and neck that was published, I guess in 2010, where a gentleman had head and neck lymphedema, and they were pushing the fluid to the back of the neck because he had a scar line, and the dogma is that lymph does not cross the scar line. And he was getting progressively worse. And so we imaged him, and we saw these beautiful lymphatic vessels that crossed the scar line. And the therapist then redirected the treatment so that they would push the fluid across that scar line and the swelling up. And we did really cool imaging to look at swelling, the volume of his face, and the swelling did go down. So yeah, there are some cases where I think the imaging would definitely assist. But again, I would much rather us treat before there is swelling, right?
Right. Yeah. Back to the beyond edema. This question says, I've worked with breast cancer patients and assessed edema in the affected arm prior to any surgery or radiation. Any thoughts on this? Have you completed any assessments that you have completed prior to surgery or radiation?
Yeah, there's a study that's going on right now in MD Anderson with Melissa Aldrich. And the only thing I can say is that she does see, you know, especially if someone has metastatic cancer, right? So you have these lymph nodes that are somewhat obstructed, and there's, you know, it's immune privileged, and she has seen dermal backflow. So there are situations where that dermal backflow could be indicative of a metastatic cancer.
Thank you for that. This next question, you had shared a patient that you had imaged with rheumatoid arthritis, and this person asked, do you think that the imaging will be useful in the treatment of rheumatoid arthritis or other autoimmune diseases?
It could be, think about it. It's a brand new idea, right? People aren't thinking that the autoimmune disorders they're saying it's a dysfunction of the immune system. But this is like my slide that I said the lymphatics are part of the immune system. So, we don't know. And before we can get to clinical implementation, we have to do some clinical studies, right? So the autoimmune disorders, it's an enormous market because of drugs. The market, I can't think of it off the top of my head. I want to say something like $90 billion or something like that. Don't quote me on it. But if you give these rheumatoid arthritis drugs, these biologics, they have something called dose creep. It's effective for a while, and then you have to give more and more and more, and then they stop working, and you have to switch drugs. The other thing is that these drugs work in like a third of the patients. And then there's something called this autoimmune induced, it's called ALS. I'm blanking on this. There's adverse events associated with these drugs themselves. So I mean, I think that the way we treat autoimmune disorders is let's just give them a drug. But we haven't really thought about the autoimmune disorders in terms of the lymphatics, destroying joints, the rashes that are occurring. They're regional and they're within watersheds, lymphatic watersheds. So maybe that's a research area.
Yeah, I think that
better improve treatment.
Absolutely. This next question asks, has there been a study that shows the percentage of patients that have dermal backflow after lymph node dissection or radiation treatment?
No, we need to have studies done. These are, we need to do the studies, and they're not large studies, because you can design your studies so they could be rapid and quick. But we've done some of them here, and we need more of them done.
This person asks, what do you think about the COVID vaccine and whether it could overwhelm an immune system in some individuals depending on their position in their cancer treatment journey? Many patients are asking now whether to get the vaccines and if they think it will increase their risk for developing lymphedema.
Okay, that's a great question. And this is just my thought, okay? I told you that immune responses are set up regionally, right? So when you get a vaccine, you get a vaccine in your arm, and it's going to these lymph nodes to set up the immune response. Now, if your cancer is not in this arm, okay, and let your cancer be dealing with another part of the body in another watershed, you can tolerate that. It's a phenomenon called immunodominance, right? If you had more than one antigen, more than one infection, maybe like a bug bite and a bacterial infection, you can overwhelm these lymph nodes, right? Because they're going to be basically educating T cells and B cells to this antigen, that antigen, all these antigens at once. And what happens is it's called immunodominance. The immune system can't handle all those, right? In that lymphatic watershed. That's why the lymphatics have evolved so that we have separate watersheds. Our immune responses are set up in separate watersheds. Turtles, we did the study with Heather Hetrick, and hopefully we'll be publishing this. And we were imaging turtles. Turtles have a circulatory lymphatic system, right? And it's thought that when we evolved from the oceans and we stepped onto land, we encountered an awful lot of antigens. And if we had a circulatory lymphatic system, we would have one immune system, right? We would generate, whenever we encountered an antigen, the whole immune system would respond. And we would have immunodominance. We couldn't handle all the antigens. So it's not that when we left the sea and went to the land, okay, and we encountered all these antigens, we evolved so that we had separate watersheds, lymphatic watersheds. So we could handle more than one, more than a few antigens at a time without overwhelming the immune system. I hope that answered your question. So the question is, can a cancer patient get a vaccine if they're in separate watersheds?
Yeah, I love that answer. That's fascinating. This person asks, do you worry that compression or pumping so soon after surgery or radiation may cause harm by disseminating any residual cancer cells systemically?
Everybody talks about that, but no studies have been done. And if you're going to be trying to encourage the lymph to move, you're going to be encouraging the lymph to move to the lymph nodes where there's immunity is set up. I tend to think if people are not immunosuppressed, and the lymph is flowing so that you can set up immune responses, I think that should be a positive thing. If there is lymphatic dissemination, like it's kind of interesting. I was going to talk about this and I stopped. In breast cancer patients, if a breast cancer patient has a lesion here and they get the radiation, it turns out that they find that it's called the abscopal effect, that when they have the radiation and those neoantigens are all draining into the lymph nodes and the T cells are activated, the antibodies are activated, and then it goes into the bloodstream. It turns out that once it goes to the bloodstream, it will impact a cancer in a field that's outside the radiation field. So we know that we irradiate a tumor and this tumor will get smaller because of that systemic immunity. So I think that the greater effect, this is a research tool, we have to figure out, is the greater effect that you're establishing tumor, anti-tumor immunity, or we're not. And if we're not, we might be getting metastasis. So the question is out, but from the radiation treatments that we see, we know that when you give a radiation treatment to this tumor will go down, even though it didn't receive any radiation. It's because the radiation is revving up the immune system. And when it revs up the immune system, it has to go to a regional lymph node to rev up the immune system. So why not massage? Why not do the MLD? It's controversial.
Well, thank you so much for that answer. I hope everybody really enjoyed this presentation tonight. I know I learned so much. Thank you very much, Dr. Sevick, for your time and expertise. And thank you to all of the attendees who made time for this evening. We really appreciate your presence here. We did just want to share, if you're looking for future educational opportunities, we do have 3 upcoming webinars. The Managing Chronic Edema course is a continuing education course that you can get credit for, and that is happening Tuesday, March 16th. We also have a CE course on Lymphedema, the overview and treatment, and that is on April 7th. And finally, on April 15th, we have a presentation about breast cancer-related lymphedema and management using modern risk assessment, surveillance, and care pathways. So you can go to tactilemedical.com/learning to register for any of these, and also to view this and other previously recorded webinars. But thank you, everyone, for your time this evening.